menstruation and breasts, and to comprehend everything we're going to study. Let your name be glorified in our life. Thank you because of our prayer for praying in Jesus' name.
Amen. Have I sent you the recording?
That's not so.
I'll send it to you. It was interesting. It's not the best, but excuse me, the everybody is not big.
How by singing, I have decided to follow Jesus. What pains me about that song is that the person singing the song is contrary to Jesus. I have decided so that if you know the story behind that thing.
So I'll send it to you. The beautiful thing. The beautiful thing is that it wasn't a waste. All the things we were talking then. I mean, you can just relax. You know when you cannot read. Let's assume you are not able to read for exam.
Wow. This is, I'm looking at Martin Leo Jones, Dr. Leo Jones.
Is it Leo Jones I sent to you?
Jonah, eh?
I'm so sorry. Maybe it's divine. Maybe you should listen to the Old Testament from Martin Leo Jones.
Okay,
I'll send it to you now.
no, don't worry, just leave it.
I'll send it to you now. Let me see. I've sent it.
I'm actually studying Old Testament.
Old Testament.
Mm.
Listen to him, boy. The guy is very passionate. It's very good.
I'm in Zechariah now.
Wow. In fact, somebody challenged me today with free thinker theory. And God help me, I was able to write an epistle according to a piece of free thinkers. Leave the laptop and play with your blocks. I will say by the grace of God, it was from a lot of things I learned from Dr. Jones and also from mission studies. I never need to write the epistle and the reboot out to the person. So now where did we stop? So good. This is all stuff. So let's go to the next question. We have done Dr. Ecclesia and all this.
Then you were talking about pastor's message or something later, Abi.
Okay, pastor's message. I'll play it for you now. Let me show you. I'll put it in our WhatsApp group. But I'll say so when just relax. Anytime what I mean by relax is that anytime that you are relaxed, you don't want to read, you are tired, just start playing this video. Even on your phone. I'm telling you. Just start playing this video. Even on your phone. You will just see something that
I'm getting loaded with stuff, Abi.
You just see that yourself, you see yourself getting information and all that. I'm telling you, heavy information on this, I'm telling you. I will send it to your WhatsApp. The thing is on Instagram. It's on Instagram. Later you will see it. Maybe when
I'll see it later.
Okay. Very interesting what you said. In fact, we're so happy in Burundi missions. All of the following statements are true regarding the location of breast lesions, except all the following statements are true. Many leaders are kind of scared of young people in the church, maybe serving God in one way or the other, or maybe some people starting like Pedro's Baba now that has the drama ministry, they will persecute people like that. Anybody that kind of has a ministry that is not confined solely to teaching inside the scripture or being 100% inside the church, but you are going out and you are doing evangelism or you are doing anything outside, they kind of feel scared of it, and so that was really controversial. Anyway, can I answer this question?
Maybe true, super, except
in biology. I'll say D.
It is D. Although that theory of failure of milk line to evolute has been modified, it's not the whole story of ectopic breast tissue. Are you aware?
I don't even know the biology in the first place.
Okay, some people say, I think you should know those theory as regards ectopic breast tissue, that failure of milk line to evolute. But right now, some people even say some ectopic origin breast tissue are primary to that site, not necessarily failure of mammary of the milk line to involute. Like if you see a breast tissue, let's say in the inguinal region now.
So D. I'm in a class. Can't you say I'm talking with someone? Class. Yes, I'm in a class. Yes. Sorry.
So D.
So this is the answer. Yeah. So correct. Ectopic breast tissue cannot demonstrate the changes seen in image. So D is the answer. Let's see. We are right. So look at Mr. C's option before look at this option here. So according to Mr. C, so pulmonary breast tissue or polypelia. What is polypelia?
Multiple nipple.
Very good.
Or multiple nipple or multiple breast.
No, I think you are correct.
Yeah.
Let's check it.
Multiple nipples, yeah.
I think we can go 4 hours, 3 hours actually. The way you are sounding this night, you look so very energetic.
There are two ways, either 3 hours or just finish up everything. If you can able to finish everything 2 hours,
Yeah,
all well
because
and good.
the video to be complete. I
Hmm?
even submit my international passport today to YouTube so they can allow me upload more videos because they give me video limit upload. So I want to, if you watch these videos, you will be excited to do more videos, and our video quality will keep getting better and better. Before you know it, if you finish all the subjects, forget it. Anytime I want to write exam, just listen to our discussion, and you'll be familiar with it. It's not something that is so abstract. I know we did a lot of other research inside our studies that made it rich and robust. It's not as if we're just clicking the answers and going. No. Polytelia means supernatural nipples. You can see now videos. Normally, I notice that we diverge to confirm something. You know, it will soon be redundant. Some of the things we confirm are redundant, but at least now it makes sense to me. For example, now there was one question that we didn't know the answer before. We didn't know the answer of salvage mastectomy. Remember, we didn't know what salvage mastectomy. We went back in that video. I was to go and check out the meaning of salvage mastectomy. If you are going to church, somebody is driving, just be listening. But if you are driving, that's the only time you not have the benefit. So this supraliminary breast or polytelia occur as a consequence of failure of the milk line to evolute. These conditions result from the incomplete regression of the embryonic milk line, which runs from axilla to the groin. During the 5th week of gestation, breast tissue, according to this one, they say breast tissue is derived from the non-evoluted milk line. Option 2. During the 5th week of gestation, thickening of the epidermis begins, forming the milk line, which extends from axilla to the groin region. And that side is true. Say this describes the normal embryologic development of the mammary ridge or milk line. So this one say the milk line is bilaterally located on the anterior surface of the body. Breast tissue identified in the axilla may represent either ectopic breast tissue or the axillary tail of the breast. If the tissue is contiguous with the breast, it represents the axillary tail of the breast. So the answer is true. Axillary breast tissue can be part of normal axillary tail of Spencer or represent true ectopic tissue. If it's contiguous, is is axillary tail. If it's not if it's not contiguous, then it is axillary tail of breast. Okay, good. Then the mammary ridge involutes except in the region of the chest and subsequently downward. Now, and subsequently, downward growth of the epithelium into stroma is seen during the 15th week of gestation. And the answer is true. This reflects the normal timeline of breast development. So the breast is from head to the. So let's look at ectopic breast tissue cannot demonstrate the changes seen in the image. False. Ectopic breast tissue is histologically and functionally similar to the autotopic breast tissue. It can undergo the same physiologic lactation, hormonal pathology changes such as mastitis, fibroadenoma. It can undergo anything like breast normal location. What do they mean by this? But Mr. Chat didn't even see these changes. What changes are these? What will you call this?
Okay,
They look to me like papillary BCIS.
looking at this here, but is it popular now?
You know, I see there are some. I see some micropapillae. Not really micropapillae, but I see it looks papillary. It doesn't look. And some here it looks like coronal cell changes or UDH. No, it's not UDH because they look monomorphic.
Okay.
They look monomorphic. Let me add this. Let's see.
Are they looking atypical?
No, this is like low grade DCIs or introductory
Or
papilloma.
usual doctor paper?
Yeah, usual doctor because of this peripheral lumens here. But look at this. It's papillary. Can you see the papillary core here? Look papillary. Look at it. This is papillary core here. The vascular core. This is papilloma.
Or stroma? Is that not the stroma?
Yeah, stroma now projecting like papillary core here. I think this is,
Mhm.
but let's see. Just see, can't even know what it is. This is normal, non-neoplastic breast tissue. This is not.
Remember the
What is the meaning of the word autotopic?
the image depicts, look at what they explain, their own explanation. The image, fourth paragraph, depicts proliferative cystic disease. Any change that can be identified in the normal breast parenchyma, including cystic disease, peripheral changes with or without ATPI, and carcinoma can be seen in the ectopic breast parenchyma. And it comes to my mind because of all those cystic connect.
Entity like proliferative cystic disease. I think it should be a
Yeah.
coverage for something. I think it should be an umbrella for a lot of words.
Mm.
What is proliferative?
Although under proliferative T disease, that could also be epithelial hyperplasia.
Proliferation of duct, proliferation of apocrine metaplasia, UDH, ADH, proliferation adenosis. Examples. Examples.
There's
Babylon,
this one.
UDH. Anything apart from DCIS is proliferative cystic disease. UDH, proliferation adenosis, papillomatosis, radial sky, ADH, ALH. So all of them. So anyway, let's go to the exciting path. I'll take my path, then you take your path. Breast life cycle changes. expand, and explain.
Have we started recording?
Yes. So this adult female breast is modified. It's a modified specialized cutaneous glandular structure located to the anterior chest wall, overlying the pectoralis muscles. The breast is a target organ for a variety of hormones that regulate development and physiologic function. Look at this one. Unlike introduction, the dynamic nature of the breast. Unlike most organs, the female breast undergoes continuous remodeling, influenced by menarche, pregnancy, lactation, and menopause. True or false?
True.
What other organ in the body changes a lot?
Endometrium.
Yeah, not the uterus. Yeah,
The uterus.
they're right. The endometrium in the uterus changes a lot. And, every cycles every month. But the endometrium too, the uterus too can enlarge during pregnancy. It doesn't change much as the breast, but it only enlarges and comes down. Hormonal changes can affect the breast. Cyclical histologic changes can affect the breast. Let's look at embryologic and fetal development. Milk lines. Milk lines like mammary ridges form during the 5th week of gestation, extending from axilla to groin. Normally, regression occurs except at the pectoral region where the breast buds form. That's what you said so far. Give to mommy. The stroma differentiates first, then induces epithelial downward growth, forming 15 to 20 epithelial cords. Canalization is promoted by placental hormones. Canalization is promoted by placental hormones, that is canalization, okay. Clinical relevance. Supernumerary menopause, polytelia, or ectopic breast tissue may develop along the milk line. This can lactate or develop tumors during pregnancy. Ectopic breast tissue may develop along the milk line. Okay. The supernumerary menopause, okay. Okay, let's continue. So, supernumerary menopause or polytelia or ectopic breast tissue can develop along the milk line. And they can lactate. Wow. It can also develop tumors during pregnancy. Why during pregnancy? I don't know. Maybe because of increased hormone stimulation. At birth, neonate has nipple and large ducts only. Some neonates may produce witch's milk due to maternal hormones. Hello, are you there?
I'm there.
Witch's milk. What is witch's milk?
People make secretion due to maternal hormone stimulation.
Yes. My baby was born with bilateral gynecomastia. But it resolved it within 1 week to 2 weeks. He resolved completely. Where are we now?
Puberty.
No. Turner stages. Turner stage 1, 2, 3, 4, 5. Right? So Turner staging. Okay, puberty, sorry. Puberty has Turner stage 1 to 4. These stages,
Wow.
ductal branching and TDLU formation, terminal ductal unit formation is what happens during Turner staging. It's a terminal ductal. This is duct. These are lobules. So terminal duct lobular unit formation. There's stroma proliferation and adipose tissue deposition. Turner stage 1, nipple elevation, no glandular tissue. birth. 2, subareolar. Okay, no. Maternal stage 1 is when the nipple, that's puberty. Then subareolar mound appears. Then 3, more glandular tissue, larger areola. 4, nipple areolar complex forms a secondary mound. 5, full adult breast contour. Lesions, rare during childhood. Security carcinoma. Hey, you mentioned security carcinoma before, right?
Hmm?
You mentioned security carcinoma before, right?
Yeah.
You said is a pediatric breast malignancy. What other malignancy is found in pediatric patients or who 20 years of age or thereabouts?
Another pediatric breast malignancy, right?
Yeah, so medullary carcinoma is found in 20, right? Um,
Is it not that is medullary not found in elderly?
medullary what? I didn't hear you. Medullary what?
Carcinoma with medullary features. I think that one is in found in the common name, the elderly female.
Ah, I didn't know that. Let me check what breast cancers? Hmm. Actively rare. Secondary carcinoma. The only thing I came up here is secondary carcinoma. Epidemiology of medullary carcinoma.
No, the right name now is
What?
invasive breast carcinoma with medullary features.
Yes, invasive breast carcinoma with medullary features. I agree. Yeah, that was what we were told then. Medullary carcinoma with intravenous ductal carcinoma with medullary features. 40 to 50 years of age, associated with BRCA1. Okay. Okay. What of this tumor that metastasizes early? What's the name? That has empty spaces around it.
Micropapillary.
Yes. What's the epidemiology?
I can't remember that.
Micropapillary carcinoma, 50 to 60. There was a tumor we saw that was that. I think it should be secretary. Okay, cervical carcinoma is a rare pediatric breast malignancy, relatively favorable prognosis. In patients with cervical carcinoma, yes, you avoid, okay, no. Avoid surgery in benign masses to prevent damaging developing breast buds. So if somebody is less than 20 years, please don't remove. Somebody is 14 years old and is coming to you with a breast swelling and you diagnose fibroadenoma. What we advise the surgeon to do in Nigeria. American surgeons will already have guidelines, but Nigerian surgeons may want to remove it. So tell them please they should defer surgery to prevent damaging the developing breast buds. In that way, you can save that child. Hello?
Yeah, I'm with you.
Is it a wise thing to do? Or to just allow the surgeon to act, don't report and allow the surgeon to act in his own discretion?
Well, this one would have been, you know, a a suggestion based on data. Huh? Normally, you may want to say, doctor, remove it. But if they have data that back the fact that there could be damage to breast uh, ducts, then it will be better to defer. But that thing will not involute on its own. The mass will not remove on its own until the woman becomes get to menopause. Maybe when it's the woman is mature very well, the adults become adults, then you cannot remove it.
Yeah, that was I say. So I think our report, we used to have notes. We say according to AJCC or this disease, quote the people and said your tumors can be monitored until adulthood for removal to avoid damaging breast bud. So just be feeling insulted, but you just word it in a way that won't insult them, or just providing basic pathology information.
Oh,
Especially
isn't it, after they have removed it, that's when you now send notes to them?
they only do biopsy now.
Okay.
No, they'll do
It's
biopsy for removal to know what it is, isn't it? Nobody knows
okay.
what the
Oh,
mass is. So the surgeon may be, especially if the person some people are not surgeons in Nigeria, they are just general GPs that are doing surgeries. And they believe they can enter any part of the body and do anything. I was told of a case where somebody presented with a pelvic mass and they went in, they didn't even know what the mass was. They just went in and they successfully removed the mass and were excited. Especially that they develop kidney failure. Only for them to discover that what they removed was horseshoe kidney. They did bilateral nephrectomy and ended the patient's life
where is that one? Happen? Where did it happen?
in Nigeria.
How did you know?
I heard the story from somewhere. You know, somebody sang what the Igbo sang a song. Many things they happen. Many things they happen. Darling Jesus, they help me. Many things they happen. I shall never go astray. Many things they happen. So please help them. I write reports and make suggestions in a very subtle but not condescending manner. So I wish the radiologists, I don't even know whether they did radiology or ultrasound. I wish someone told them, they wouldn't have gone. And in Nigeria, I can't even sue. They don't, maybe these days people are now suing. I just see is where. Maybe that's how the law wants it. I don't know. Male breast, typically rudimentary, consisting of large ducts only. Lobules are usually absent, so males have no lobules. Gynecomastia is the most common lesion, especially during puberty or with drug use, such as steroids. Rare tumors like myofibroblastoma can occur in males. Yes, myofibroblastoma can occur in males too. Gynecomastia can occur from steroids and the other rest. So the menstrual cycle phases of breasts. Wow, proliferative phase, day 3 to 14, is driven by estrogen. The breast is quiet, minimal glands, low stroma density, and low water content. Luteal phase, estrogen plus progesterone. They have terminal ductal lobular unit proliferation, increased ACNI, edema and stromal expansion, breast tenderness in some women. Menstruation. When they are menstruating, they'll be dropping hormonal levels and the lobules will begin to regress and a reduction of edema. Pregnancy-related changes. Early pregnancy, there will be lobular hyperplasia. Glands begin to proliferate. Have you seen this, they call it lactation adenoma before?
Yeah,
The first day I saw it, I was so excited. I diagnosed it myself.
you see a lot of eosinophilic secretions.
Yes, it's the white one, So lobular hyperplasia. So you see, glands proliferate, stroma regresses, pigmentation of areola increases, Montgomery tubercles enlarge. What are Montgomery tubercles?
Maybe those subareolar uh, tissue.
Mhm. All right. This is the bumps on the areola. They're called the Montgomery glands. They're about 0 to 38 per breast, but the average is 9. Montgomery glands. So everything anatomy has name. It is well known. These ones, Montgomery glands. They increase during 6 to 8 weeks of pregnancy, 16 weeks of pregnancy, further pigmentation, and more Montgomery glands. Let me see. Yeah, done. Okay. Now, ChatGPT has made life much easier. Although this before I would have still gone to Google, but at least late pregnancy, luminal cell vacuolization, myoepithelial differentiation via oxytocin. Myoepithelial cells begin to differentiate, milk precursors begin to form, and they begin to, like colostrum, begins to form to accumulate in the AC9. Postpartum, milk production is stimulated by prolactin, growth hormone, and insulin. Milk ejection reflexes via oxytocin. Changes regress incompletely after cessation of lactation. So diseases that can arise from breast include lactational changes. Lactational change, you will see prominent terminal ductal lobular units with vacuolated cytoplasm and somomatous calcifications. Lactational adenoma, benign self-subscribed nodule, and mimic neoplasm. Lactational abscess, you see cracked nipples, staph aureus, baby neutrophils, galactocele, duct rupture, and milk extravasation, triggering chronic inflammation. Febrile adenoma infarction due to rapid proliferation and limited blood supply. Febrile adenoma may infarct. Bloody nipple discharge, often benign during pregnancy from ductal remodeling. Bloody nipple discharge. Carcinoma during pregnancy is diagnosed in 1 to 3,000 to 10,000 pregnancies. Diagnosed late due to overlapping symptoms with pregnancy, and there's low index of suspicions. Tumors may progress rapidly due to pregnancy-associated stroma remodeling. Risk temporarily increases postpartum, but long-term risk decreases with early pregnancy. I don't know what that means. So risk of cancer increases. Okay. Risk generally not okay. So early pregnancy decreases risk of breast cancer, but when the risk may temporarily increase during postpartum, I don't know. Lactational changes, you see prominent nucleoli, mitosis, necrosis that can mimic malignancy. It's crucial for pathologists to know whether a patient is pregnant or lactating. Because you see prominent nucleoli, mitosis, necrosis. Involutional changes, perimenopause to postmenopause. There will be terminal ductal lobular unit atrophy, epithelial cell atrophy, fatty replacement, fibrotic ducts and regrowth, mastitis obliterans, reduced density, improves mammographic sensitivity. Vascular hormonal effects, vascular classifications in a train track pattern seen on imaging. Hormone replacement therapy or obesity-induced estrogen changes can reactivate breast tissue. Failure of involution of the terminal ductal lobular unit and resins may prolong the risk of cancer. So we see the nipple here. The nipple areola are covered by pigmented squamous mucosa, epithelium, and contains sebaceous glands. These are the it's even here. Montgomery tubercles. During lactation, milk is produced in the lobules and is transported via ducts that led to the nipple orifice. Early breast development. So these are large ducts that grow downward. So the stroma is the first breast tissue to specialize. Not the duct, the stroma of the breast. This stroma is the first to specialize in the breast of the patient. The overlying epithelium is induced to grow, the epithelium will begin to grow downwards and form large ducts. And this skin epithelium will to grow downward, form large ductal structures. And this so the ducts are the first to form, not the lobules. So let's now look at puberty. Prior to puberty in females and lifelong in males, the breast consists of large ducts and terminal end bonds in loose cellular stroma. This pattern is characteristic of gynecomastia in men, juvenile hyperplasia in women. You call it gynecomastia hyperplasia. which is diffusely present in both breasts. Oh, juvenile hyperplasia in women occurs when they are still very young, when before puberty. And then gynecomastia hyperplasia in men, in women. Mm. This is a mammogram of a young woman that is very dense and may obscure mass forming lesions. So what's the best test for testing the breast in women, young women in their early 20s?
Ultrasound.
Ultrasound, very good. At puberty in women, the terminal end buds give rise to acini and form lobules surrounded by specialized stroma. Interlobular stroma also increases in quantity to form the bulk of the breast parenchyma. So what we know is that fifth week of development, the breast stroma begins to expand. The overlying epithelium begins to invaginate, eventually to form small ducts that will wait there till puberty. Then the ducts will begin to form acini, and specialized stroma will surround the ducts. So,
External form lobes.
hmm?
External form lobes.
Yeah, acini that form the lobus. Yes, yes, yes. Acini now form form acini and lobus surrounded by specialized stroma. So during lactation, the breast appears nodular and dense with a coarse pattern due to increased amount of glandular tissue and breast milk. Mammography should be performed immediately after expression of milk, which will decrease density. So if a woman wants to perform mammography during lactation, tell her to breastfeed her baby or express it into a milk collecting container, like all these what do you call it, suction pumps. Once she has finished expressing the milk, it removes all the too much density, enabling the mammography to be more sensitive. Wow. During the first trimester of pregnancy, epithelial cells proliferate rapidly, and there's a great expansion of both size and number of lobules. So first trimester of pregnancy, lobules will expand compared to pre-pregnancy state. Look at this. This black arrow is the pre-pregnancy state, which you normally see. This is pregnancy state where the lobules have expanded significantly. The acini dilate and the cells undergo secretory changes in preparation for lactation. Pregnancy. During pregnancy, the luminal cytoplasm becomes vacuolated. Mhm. The nuclear enlarged with prominent nucleoli. So this is during pregnancy. So you can start seeing cells like this that have prominent nucleoli. And this is mitosis. One will be tempted to think that there is cancer, right?
Mm.
So
Yeah, but if they are not looking so um, you know, hyperchromatic, you know,
pleomorphic.
pleomorphism, yeah, you could still know that it's benign.
Everything is like having lumen, Like here, it's not like if they are less than 75% lumen. What's the criteria for tubular carcinoma again? Remember?
Tubular carcinoma is lined by single layer of epithelium.
Yes, but how many tubules do you need?
I can't remember the number of tubules, so I don't know if there's a criteria for that.
The criteria
But
nine.
the tubules have
Stated that it
description.
must be at least 90% of tubules. We call it tubular carcinoma. In
Okay.
fact, there are some low-grade invasive carcinomas that have, you know, maybe 75% of tubules. Because such a low-grade invasive carcinoma, you must have more than 75% of tubules to call it low-grade. Then that's grade 1. Then 10 to 75 is grade 2. Less than 10 is grade 3. The other plug you. Wow. So mitosis are frequent in the first trimester. Epithelial cells become inconspicuous. These changes can mimic malignancy. So let's see. Okay. Pregnancy. Pregnancy, the large duct system. This is pregnancy, large duct system. Can be distinguished from the TDLU during pregnancy and lactation because lactational changes occur only in the luminal cells of TDLU. Okay, so the ducts, there are some large ducts that even in pregnancy will not change. These are the ones that go to the breast, to the nipple. Lactational changes only occur in the terminal ductal lobular unit. There's some abrupt transition in the terminal ducts. These are terminal ducts. When you get there, they don't change, but these ones will change, you know. These are corrugated, what do you call it again? Obnally. Only the luminal cells of the terminal ductal lobular unit undergo lactational change. So lactational changes will only occur in luminal cells, not my epithelial cells. And they produce milk. So where does production of milk come from? Luminal cells or my epithelial cells?
Luminal cells.
What is the function of my epithelial cells?
It's for support now.
Yes, and for contraction to expel breast milk. Right. Where does oxytocin work on to release breast to produce to contract contract and release?
Luminal epithelial cells.
Yes, I used to memorize those bits before when I was not a pathology person. I'll just say memorize and forget. My epithelial cells sounded to me like one kind of fancy name. I never knew how real they were, what they were. The luminal cells of the large duct system are not producing milk. So the luminal cells of these large ducts don't produce milk. The luminal. The biological reason for this different response to the hormones is unknown. The luminal cells don't produce milk, but the terminal ductal lobular unit produces milk, whereas the large duct system doesn't. Lactation adenoma. Is lactation adenoma? Is it a hyperplasia or a neoplasia?
Hyperplasia.
Good. Look at it. Exactly. This is what I saw. There's a lot of white secretions. Not white, a lot of secretions in it. No, this is end of lactation, sorry. At the end of lactation, the lobules regress. A prominent lymphocytic infiltrate surrounds the lobules. Wow. These lobules do not completely regress back to the pre-pregnancy states, but they regress. Inflammation come and regresses it. These are subnormal bodies linked to calcification. What can what can cause subnormal calcification?
It's related to pregnancy or sickness among youths.
Yeah.
But normally, one may be tempted to think this is pathological.
Okay.
One may be tempted to ask whether this is pathological.
No, it's not. This is physiological.
Mm.
That occurs,
Would it be part of cystic change
yeah.
if we are to give diagnosis?
Um, let's find out. Let's not just assume. Let's see.
For diagnosis, we know causes. We just
This so it's associated with,
diagnosis.
it's associated with lactational changes actually. I think
Okay.
I said it earlier. The historic classifications and of course, a set of injury or degeneration, concentric carry, they are concentric and laminated, round oval structures. They appear in benign lactational depressed tissue. Sporadic lactational change, non-pregnancy related, like pituitary microadenoma, stress-induced prolactin release. When the breast is undergoing lactational change outside of pregnancy, it can occur.
Mm.
Benign apocrine secretory activity, vesicular secretory material, subclinical ductal obstruction, obstructing breast milk, mechanical trauma, evolution remodeling, post-pregnancy. So some of the debris may calcify the ducts and lobules.
Mm. Okay.
This is a recent breast, post-menopausal mammography screening. This evolution. During evolution of the breast, lobules and specialized lobular stroma begin to disappear. The lobules are no longer found here. Only small terminal ducts and left are present. The interlobular stroma becomes less fibrous and more fortive, making the breast more radiolucent. So this is what happens in menopause. In menopause, the lobules begin to go away. You only have terminal ducts here and there. So, and then if the stroma here that used to be fibrous, it's now being replaced by fat, allowing X-rays to pass more to lay up in less reduced dense breast, a less dense breast. Lobular atrophy. This lobular atrophy. Epithelial cells and basement membranes become more prominent, and luminal cells regress. Epithelial cells sometimes appear spindle in shape. Mastitis obliterans. What does that mean?
Included duct recanalize, forming pattern of mastitis, double joints. The duct is shrunk the smaller ductus glandular structures.
You understand what I mean?
Mm.
You understand what this slide means?
Yeah, the duct is now surrounded by The duct is surrounded by epithelial structures.
The ducts.
You know, it's surrounded by epithelial structures.
Mm-hmm.
So the like a recanalization of the ducts.
Which
Maybe
duct?
normally the duct should have involuted, become small, but becoming mal expanded again.
Anyway, let's do that one that see safe. This myositis obliterans occurs in age or postmenopausal women. Even the just a minute, please. Who is that?
Go back in.
Let's hold on, sir. I'll get back to you.
Your naked body, though.
Hold on, sir. I'll get back to you.
Okay.
I'll break it. Okay. Look at this. Did you hear this?
A state overseer called me and said, there is a dependable worker in their state. He goes there, and he does evangelism, crusades. But they didn't appoint him to do that. The overseer wanted to tell him, hey, come on, sit down there, don't do that. And he wanted my input, either to support him, to say, yes, you're right, this is deeper life. And that young man has not been appointed to do something like that. Shut him up. But I remember what I received from my own religious fathers. That I was doing evangelism, I was teaching Bible study, and because of that, they wanted to shut me up, and eventually they excommunicated me. And when I remembered, no, that happened to me, this young man, I will protect him, it will not happen to him. So I said, overseer, appoint that person to become a state evangelist. Why? Because he has the calling, like God called me 1973, and the gift was there, the vision was there, the calling was there. And instead of the people fanning the flame and making it large, they threw me away. I said, in my own leadership, I will not throw anybody away. What happened to me will not happen to them. What happened to me will not happen to you.
You understand how this help was so meaningful to people like me. We have been persecuted heavily to an extent because of Burundi missions. Anyway,
We persecuted where?
in the US here.
Which one is persecution? Yeah, are you being Burundi mission? Yes.
No, I'm not in Nigeria now. When the head of it, they persecuted me.
Eh?
They persecuted me
Where?
in my church here.
Okay, when they heard that you are doing Burundi mission in Nigeria.
Yes. But my overseer told me that I was leading a group of backsliders.
What does that mean?
I don't know. He said, are there any deeper life people in that missions? I said yes. He those deeper life people are backsliders.
The different people there, Abi.
Uh, so
Which
eventually,
is that persecution because somebody talk, Abi?
and they also stopped me from it's kind of persecution now. For almost 1 year, I was not allowed to do anything meaningful in the church. That there was like discipline. But it's well, it's beginning to fade. I've not been talking about the missions. I've been so quiet, so they are beginning to change towards me. It wasn't easy. Okay.
Even you yourself, why are you even?
I was treated as like an outcast. But let's leave it. There were some leadings that made me talk about the missions or because of support and other issues. But now they are changed. I think their attitude have changed now towards me. I think they're beginning to see the light and they're now changing. But I'm grateful to God for that. But it wasn't easy that first time.
Jonah, even you yourself, I'm just wondering if the mission you are doing is not, if that thing is not in the US, and it's not like maybe you need their input. I don't know why you are,
Actually,
telling them.
I actually needed their input in a financial way. Anyway, so that was what exposed me. So ever since I learned my lesson, I've been very quiet. And the more quiet I am, the more peace I have. It's just like Saudi Arabia. As far as you don't preach Jesus Christ, there will be no rebellion against Christ. But the day you mention, you will put up a church in Saudi Arabia, that's the way you know that Saudi is not a peaceful country. People come to Saudi and say, more peaceful than Nigeria. Islam is a peaceful religion. It's not true because there's no church. The day they see any church, Deeper Life Bible Church, they will burn it down. That day you know that Saudi Arabia is not peaceful. So sometimes to get your peace, be quiet. And it has helped me a lot. So, in fact, it was serious. I told one of my senior mentors, he wanted to contact GS on my behalf. The guy is a regional overseer. I said, no, I ran away from him. I didn't.
See that the thing is, me, I've learned my own lesson. That
You know, they invited me to minister at Impact Seminar when GS went to Abba. They invited me,
Abba,
yes, Abba in Abia
ne-
State. So for GS,
okay, when you are in the US,
yes, they invited me to minister via online to the Impact Youth. My overseer canceled it. He said I can't.
okay, they invited you through him or invited you directly.
They invited me directly because they knew me in
So
the
you now went to tell him, Abi, that they
so just
wanted you.
out of courtesy that in case the kid they don't just see me ministering that day, it would be too sudden that they didn't know. So they say that why did they pass through the church and all that, and that I'm not the most qualified. I'm not qualified to take it. That there are better people who are more qualified than me in the region. I say they reached out to me because they knew me, not because they wanted someone from the US. That that's why they reached out to me directly, and they may not have had the brother that invited me in the committee. They don't have direct contact from they just not something like that. They just invited me. I'm given the fact that they already have issues with me with Burundi missions. This ostracized me. They ordained all the young adults. They excluded me and my wife. They invited everybody for the ordination. And they excluded us. I mean, we're treated like outcasts. Kai
Mm.
is well.
It's okay. It's okay. It's okay. I now understand what you mean by participation. But the one thing me I've learned, Jonah,
Mm,
the glory of God supersedes any human organization structure. And that is what we should pursue. That is what we should prioritize. Any structure is just to add efficiency and effectiveness to the advancement of God's kingdom. But if human structure will stand on the way, then we prioritize God's glory, and we don't look at what men will say, because
mm,
because eventually everybody will stand before the judgment seat of God. Not
mm,
necessarily for, when I say judgment, for that we are going to go to, but to evaluate the work we have done. So even if we have position in this world, people give us accolades. When we get to heaven, it's God Himself, Jesus Christ Himself, that will evaluate the quality of our work for Him. And even the person who has position, you may be surprised that by God's standards, if he has not been fruitful, the way God expects as regards God's grace and talent in his life, the person who doesn't have position will receive, you know, greater rewards. So we still going to our reward in heaven will be evaluated based on our work for God on earth. Yes, we get to heaven by grace. So I think that we should just prioritize the glory of God, and that's one thing me I live by. When I'm here. I thank God. I associate with deeper life because I've been used to the church, and I flow with the people. But there will be some things I may not like. Uh-huh. But this not that I can still, at least these are the people I can associate with for now. But that doesn't mean that everything about me will be determined by that. And for me, I prioritize advancement of God's kingdom, and I think that is what we should live by. So here, and as much as I have people anywhere I go, if I can see people that we can evangelize together where we are, I'm into it. So I've always do that as much as God. We pray, we evangelize. Like in our own city, we pray, we go. Our last Tuesday, a number of us we go to city center.
Now
So
the brother that just left here now, if you know,
mm,
I think if I'm not, I think the best graduating student from Unilag in medicine when he was in Nigeria. He finished from Unilag. He had like 4 distinctions. I think if not, I think 4 distinctions. He came in pathology and like 4 distinctions. The guy, it wasn't like a work like that, but they went to the villages to do evangelism, to plant churches. They were seeing miracles. God, Babalawo was burnt out their bushes, burnt out their charms. They saw sisters pray, I think, heal the sick. They saw many miracles. The DSCF had to call them and stop them and say no, they can't be doing that kind of rugged, that they were rebellious or whatever that that I mean, I don't know that they are all of them going there because they are boyfriend and girlfriend. They want to be befriending one another and want to marry one another. That's why they are banding together and they stop the revival. And God did so many things then, and they still. So sometimes the church, every institution, if it's not careful, it turns out to become the opposite of what it once was. After the Protestant
mm,
Reformation, we thought that was the end. Is it not the same Church of England that now stopped the so-called non-conformists from preaching the gospel? That was why John Bunyan was arrested, because he was preaching the gospel publicly. You couldn't preach those days without a license. They say, "Who licensed you?" Jesus' disciples were not licensed, and they refused to hear. The same that was almost happening in the deeper life now. They were stopping everybody from preaching. John Bunyan went and preached openly, and they arrested him. They invited him for a meeting. The brethren heard that police were coming. They warned him not to come. He just came. He came, and they arrested him. And every year they were begging him to say he will never preach. He refused. He said, "I will preach." His family were outside suffering. His daughter Mary was blind. That's how he was so touched. He was almost weeping. He started writing books to try to make money to be able to cater for his family while in prison. He was a shoemaker in part-time. Sometimes he would write a book. It was a very dirty cell. He wrote the first book and sent out. And he began to move markets. That's how he started writing, became a writer. Anytime he said John Boyan book is out, the thing will sell. That's how he used to feed his family. Until eventually he wrote one book. He didn't tell anybody. Titled The Pilgrim Progress. After I finished writing, he now showed the prisoners. Should I release it? He said, some say release it, some say don't release it. After some time, he now say, what's the let's just after he came out from prison, he now decided to try it and say, let me even see. You know that we are still reading that book today, Pilgrim Progress. He wrote it while he was in prison, 12 years imprisonment because of preaching the gospel. So a lot of time, church, the same thing that happened to Pastor Kumi is what they want to come and do to us now. God will help us.
So the Lord help you. So you people now that you are now too, that brother, what's he doing in the US now?
He's not a doctor here. He's working with some companies on medical things. He's a very brilliant person. What he do, he's making a lot of money from it. He's making a lot of money and he's comfortable. He even has his own house, everything. His wife is a dentist. His wife the wife is the daughter. You know that overseer that preached last Sunday on what did he preach about? Standing out and not selling out. You know that overseer?
Yeah, I didn't watch it.
He didn't watch it. The version that preached last Sunday is his daughter. His daughter is the wife of the brother that just left here.
Is it during Sunday service?
Yeah. That preached that the program they used to do before GS comes to preach now. After the scripture, there's a program for this month of May. The last one was just done last Sunday. So the overseer that preached that for is the Benue State overseer. He used to be the overseer for the Middle East before. You understand? I met him when I was in the Middle East, and he's the daughter of this. He's the daughter of the daughter is the wife of this brother. And this brother now is no longer, he has started his own ministry, even though he's still a member of the church, and but he has not been joining the church again because of persecution and all these problems. He left and started his own ministry and all that.
Okay, in the US,
Yes.
like his own church.
No, he has a children Bible study group that he teaches online. But on Sunday service, him and his family worships at home. I don't even know how to convince him to come back to the church. He passed through a lot of persecution related to his wedding, related to many things. So he left.
Okay. What is on my own heart is this. I believe as Christian, before we start discussing that, and that is what is my burden about Nigerian church, and that's my challenge to you. Uh-huh. Our Christianity should influence our society. It should impact our society. It should wherever we are, whatever we do, we should be able to turn some people to God. Yes, we should do evangelism. We, you know, so even both of you that have you have similar passions like that. We should be, you should be able to collaborate.
What about you?
Be,
You are the apostle,
yes.
you are the apostle to Nigeria. You have refused to accept the calling of God upon your life. So
No, I'm
just
not
ask
in
God.
Nigeria. No, 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 no.
You are
I'm
not in
not in
Nigeria.
Nigeria.
You are not in Nigeria. Cry to God. He will show you what to do. Say, Lord, what do I do?
You see, I'm in the United Kingdom now. I told you that I'm in the United Kingdom now, and
Mm.
I'm going out for evangelism. But I collaborate with people who have similar fashions, similar vision. When God knows our heart, He knows how to align us with people. And in fact, most of the people we reach out to, of course, occasionally we have like evangelism in summer in church, like we plant church in another time, like last year summer, we plant church. Many times cold here. So, but when you have summer, you take advantage of it. And this month
Of
too,
the,
we are going this
there are
summer too,
always
we are still going
exceptions
to
to the
have
rule.
some.
There are always exceptions to the rule. You don't
But
build based on Sorry, I'm listening. I'm listening.
listen to what I'm saying. I'm saying like Deeper Life Church now, we have periodic evangelism.
You remember this?
With that of God's kingdom. And so there are bound to be friction. So there's going to be difficulty. Difficulty will come. It's part of the reality. But the good thing is Jesus has overcome and we will also overcome. And when you look at the early church, what Christ told them was,
Did I send you the message? Hello? Hello? Hello?
oh, can you hear me now?
I can hear you now.
Yeah, we plant a church in another city. Yeah. Within my sub-region, we have another church now, another pastor there for our evangelism. We went door to door and all that. At the end of the day, we had another church. So this summer too, we are going to still have evangelism, but I don't know whether it's going to be another church. It just be a consolidations evangelism within the town that we're already at. So I do that in Deeper Life. But when it now come to week, outreaches, there are people in my city. I stay in Norwich. That one way or the other, God aligned my step to meet them. So we do go out. Even last Saturday, in the rain, in the sunshine, like on Tuesday it was raining. So every week you will have some people in the city center preaching, distributing tracts, you know, and you have some people they invite to churches. So that kind of thing, we should be doing that as Christians, especially when we have burdens, when we have similar passions. In fact, we should have similar parts. So I actually, that's what I'm trying to say, that
I've lost you. Hello. Hello. So what about mastitis obliterans?
yeah.
It's not an active. Oh my God. People are shouting to my screen. Sorry. It's not an active infectious mastitis. It's a chronic evolutionary process seen in postmenopausal birth as part of aging-related stomach fibrosis and ductal changes. It occurs when previously patent ducts become occluded and then later show recanalization or a reopening or creation of small new channels within a fibrotic duct. So this is mastitis obliterans. So this is a duct.
Mm.
It's a duct that is ringed by smaller glandular structures. Wow. So a duct ringed by smaller ductular structures and obliterated by fibrous tissue. And after some time, the fibrous tissue begins to recanalize. You see openings here. I don't know. I mean, I would have said these are openings in collagen. I don't know why they are calling this recanalization. Understand? So this is what we call mastitis obliterans. It occurs in aging breasts or postmenopausal breasts.
Okay, where you are describing is like the stroma now. You are not. Oh,
Oh. Let me speak. I'm listening. Stop.
smaller gametes moving around the fibrous area, you arrows. Now, I thought that the the smaller arrow is the area of the lesion.
I think
Yes, these smaller arrows.
I feel the whole ring here is the lesion. It's a duct. That's what I feel.
Which one?
The whole of this is a duct.
The hole. Okay. Where about now the what look like glandular spaces
Here, right?
surrounded by epithelial cells?
Mm.
What are they?
That's what I'm trying that's what I'm trying to understand. So like here, they said, what did I read before? When previously patent or open ducts become occluded and then later show recanalization, a reopening or creation of small new channels within a fibrotic duct. Okay, I get it. A duct, if you fall down, it's your becomes problem. Occluded by collagen, right?
Mm,
A prior duct, this is a prior duct, becomes occluded. Then the epithelial cells around the duct proliferate and start recanalizing.
that's what I'm saying.
I get it now.
Let's scroll up. Let's read the histological features in the. Let's read. It's okay.
The central duct has lost its original lumen, now filled with fibrous tissue. This is it.
Okay.
Then recanalization pattern, you see small glandular duct spaces around the fibrous area indicated by the arrows. This resemble recanalized channels. So so this is it. This duct, not how a duct, this is a duct. What do you want to do? Normally, what is then it became filled up with collagen, filled with fibrous tissue. Then these areas, the epithelial cells now proliferate and start recanalizing.
Yeah,
Forms like
yeah.
multiple rings forming into a duct. We call mastitis obliterans because someone may see this in postmenopausal breast and be like, what is this? I just
Okay, yeah. You see
that's
small doctoral spaces soon around the body.
yes. So someone may see that
Yeah.
sometimes we see what we can't even know we don't even know what it is. I don't know what to call it. Only that we know that it's benign, but we can't name it. Then this case is called what? This is an example of what? Mastitis obliterans.
Obliterans, yeah.
Okay.
Okay, I'm coming. Only you.
1 minute, sir. Good. Let's continue. What is this, sir?
Hmm. This one, okay. I said it is lobular structure. Okay, regressing lobes, large regressing lobes.
Can you describe it?
Resem luminal cells appear small and shocking and begin to grow after.
Yeah, breastfeeding.
It is a slow. It is consists of breast lobe,
Yeah.
breast lobes, but I cannot see the details of the cells that make it up.
Well, yeah, we cannot do the details because it's actually low power. But another thing is that it has a lot of thickened hyaline membranes, basement membranes. Can you see the basement membranes?
Yeah, that's where the arrows.
Yeah, they have thickened basement membranes or thereabout. No, the arrow show regressing lobe. It doesn't show memory membrane, but we see this thickened pink basement membranes. I don't know why the arrow here they say is for regressing lobules. Okay. Final thing, calcified vessel. What do you think about this?
Yeah, classification indicates train track pattern mammography are the source of suspicious cluster classification. This struggle is common in breastfeeding in women above 60 years old and rare in under 40 years. So that is common in postmenopausal women.
Okay, if I'm covering postmenopausal iron. Okay, good. So let's continue. So this is no, this is so this tram track appearance of calcified vessel is not significant in breast tissue. So it's benign. And what are the kind of classifications that are suspicious in the mammography?
Mammography. Okay, what are they?
Cluster classifications and linear classifications.
Cluster anemia.
Mm,
The type of classification.
yes.
Okay. So both cluster and anemia are suspicious.
Yes, the malignancy. Remember, if breast classifications are like how will I put it now, are like distributed randomly, like scattered all over the place, okay, then it's not suspicious. Like random classifications in the breast is benign. But if it is clustered in one area or is in a line, that means it's good. Like that means it's following a duct. Like this DCIS. The malignant DCIS. The DCIS, that high grade DCIS. Remember that it has contiguous growths. You understand? And that's the one that if you exercise it up to zero point 0.2 centimeters, you are okay. But for the distance, then what I'm trying to say is that the linear classifications means that it is following a duct. Cluster classifications means it is in a mass. Do you understand? So, but if it's random, one in the left upper quadrant, right upper quadrant, random classification is benign.
Okay.
Suspicious classifications. Let me ask in the exam.
Okay.
And if and when you are practicing too, The clinical history may tell you that this person, that sometimes they bring you that why did they take a biopsy? They may tell you linear classifications of mammogram. It means something. It's not oh God. And so it doesn't just mean sometimes, some of these things, it doesn't just mean when I first came to pathology, I'm even up to now, I'm still learning to kind of master all those indications for I don't know why they're not bringing the pictures I wanted to bring again. Okay. 1 minute. Let me see if I can bring it. The special classifications of mammography. Show pictures, please. In the exam, they may just bring it out. That's why we need to click our pictures. Very good. Let's see. Beautiful. Good. You can see this is clustered. This is clustered. The whole of the area around here, there are no classifications. In my program, when they send us biopsies for DCI or for breast biopsies, you know what they used to tell us? Biopsy A, container A, biopsy in area with classifications, area B, biopsy in areas without classification. So they have to compare both sides. And if they tell you there's classification, you must say calcium under the microscope. If you don't report it back, they will not accept the result. Because before they send the result to pathology, they will x-ray it also. So you must either exhaust the levels, you must exhaust looking for calcium, or you do an x-ray to ensure that you see classification. Because if you tell them there's no classification, that means they did the wrong biopsy. What kind of classification is this?
Okay, linear.
This is linear. Yes, it is linear. This one also.
This line is clustered. Okay, so
Look at this. This is what?
clustered,
And this is
linear.
very good. So we'll go back to this. So that's why this place, they said this finding is common in breasts. Okay, look at it. Calcified blood vessels have a characteristic train track appearance on mammography and rarely are the source of suspicious clustered classifications. So normally this is benign. That's what they're trying to say, that it's not usually, if you say cluster classification, it's not because of these blood vessels. If these blood vessels, they're not the one causing the classification. Look for what is causing that classification. Normally, under the microscope, you see that those classifications are going to be inside a DCIS, or because there'll be kind of one lesion or the other that's causing those things. So if you
Exactly.
the reason is that some people, if you report this, you're telling them that I have found the essence of that biopsy is pathologists tell us what is causing this classification. So if you report benign tram track appearance, the tram track classifications in blood vessels, you are telling them that this is what is causing this classification. Some will be like, but why is it linear if it's the one causing it? Maybe someone will say, okay, maybe the blood vessel. You may try to explain it as the cause of the classification. What if it's not the cause? Then you run the serious risk of misdiagnosing the patient. You understand? So that's it. So, and that can be, imagine another person picks it up and sees the DCIs, and then you just saw this calculation and just ran off. None like that. So we are done with this question. We just answered
We
the
spent 2 hours so with our extracurricular talking and waiting.
yes. Now we're going to finish up now. So sorry, but I'm
Mm,
glad that we are alive tonight. You know,
mm.
it's good. Sorry, that's part of life. Life is not always straightforward. So we take our questions and we're done. I think we have done all this. Let's answer 15 questions on this. And can you read through this and then we'll answer questions on it and we're done. Don't read too fast though, so I'll just follow you. Just read through it. We'll not explain anything much.
Primary basis of breast development, nuclear formation in 5th week of gestation, nuclear of mammary babies, bilateral ectodermal thickening that appear during the 5th week of embryonal development, It extends from axilla to the groin. A clinical development which mammary structure may periodically form. Can't see very well. Okay, alright. Okay, let's go to the next one. Physiology, evolution, and normal breast location. Normal process. In a normal fetus, the milk line involutes anywhere except at the pectoral region of the chest wall. The local retention of the mammary leads to the formation of primary breast growth, which will become normal breast tissue.
What you know?
Failure of evolution develop an abnormality. If evolution fails in area outside the chest, it may result in ectopic breast tissue, polytelia, which is supraabdominal nipples or both. Epidemiology of ectopic breast tissue and polytelia, superiority are seen 2 to 4% of infants, more common in African American than in white. Ectopic breast tissue is estimated to occur in less than 5% of women, though it can affect sexes. Most common site of is axilla. Other possible locations anywhere along the neckline, including the chest wall, lower abdomen, groin, and vulva. Signs and confusion with normal variant. Axillary breast tissue may be an extension of the main breast, which is tail of Spence, or a distinct ectopic focus. Tissue outside the midline, sugar bag has also been reported. While not temporarily derived from the mammary can be historically indistinguishable from the normal active breast tissue. Pathology potential of the breast tissue, cystic disease, proliferative disease, fibroma, lactational changes, infections, carcinoma, all this can occur in active breast tissue. Okay. Malignant lesions can arise also in ectopic breast tissue. Proliferate this disease in ectopic tissue. The image shows proliferate cystic disease, which includes cyst formation, epithelial hyperplasia, apocrine metaplasia. These changes are indistinguishable histologically from those seen in breast proper.
Make French fries for you. And clean off the blocks.
That's correct.
Pick up the
Thorough
dog.
physical exam of the entire midline is necessary in evaluating breast complaint of pathology. Image studies should consider ectopic location in women presented with unexplained breast mass in axilla or region. Pathology should be conscious when diagnosing tissue from
Pick up the
unusual sites, especially if the clinical history is incomplete or the site is ambiguous. Okay, these are the summary. Make class.
Pick up pressing it.
Whereby accumulation, normal pollution occurs anywhere except
Pick it up.
thoracic area. Ectopic breast result from incomplete involution. Polytelia extra nipples suffer with ectopic breast. Clinical relevance can develop benign or malignant lesion, just like normal breast. Common site axilla, other make line site possible. Important pitfall: axillary tear versus true ectopic breast tissue must be distinguished. Question. Hmm.
You know, my brain development. The milk line begins to form during which the nutritional week.
Fifth week.
Failure of milk line to regress outside pectoral region may result in what?
Polytelia.
No common location for giving breast tissue is what?
Axilla.
So you can avoid all the following except for
Endometriosis.
prevention make is true regarding ectopic breast tissue.
It can develop malignancy.
Which of the following is classified as proliferative breast disease without atypia?
Mm-hmm. Usual doctor hyperplasia.
The relative risk of breast cancer in women with usual doctor hyperplasia is approximately what?
2 times, 1.5 to 2. Okay.
What etiologic
Yeah.
feature best distinguishes ADH from low-grade dysliders?
Mm. Okay, lesson size and distribution.
Remember, we mentioned it many times.
Mm.
2 millimeter or less than 2 dots. Very important. Traditional diagnosis is best described as what?
Okay.
Mm.
Then about prevention of the status is now within low dose.
A program metaplasia pharmaceutic change is what?
Benign, non-affected with cancer rates.
Okay. Some molecular application in breast are most often associated with what?
Lactational change,
What describe mastitis obliterans?
fibrinotic obliteration and retardation of duct in aging breast.
Telephone is a hallmark feature of radial scan.
Central fibrosis with entrap gland.
Montgomery tuberculosis become prominent during what?
Lactation.
A palpable mass in pregnant woman that waxes and wanes with breastfeeding is most likely what?
Lactation of the norm.
Very good. Next question. Tell me your answer.
Hmm?
What's your answer?
Which one?
New
Okay,
question.
this one. I've not even looked at following treatment with any type of genomic change in nature and breast cancer too. Genomic changes to this.
Now, we will pick it up inside here. Put it here. Say it back. Pick it up. Pick it up.
Hmm. Hmm.
I say A.
I'll say A too. Like fibroadenoma, low grade. Yeah, I'll say A too.
Low grade carcinoma. Not low grade, not benign lesion. But let's see. I'm just using intuition to answer this question. Not as if I know all the. You are correct.
We will put it inside.
Distinct genetic factor. Low grade carcinoma, luminary, common disease 16 kilo and 1 kg. And high grades show complex chromosomal aberrations. EB2 occlusion. Mhm.
It's a genetics question. There's a lot of genetics now in breast cancer. I hope you know.
Hmm?
There's a lot of genetics now in breast cancer.
Yeah.
Ah, we'll leave it. This is my juice.
Pick it up now. Pick these blocks up. Ah,
Okay, let's continue.
you will big it.
Oh,
Yeah, pick it up. Okay. Okay.
when you go to practice, let me just test. If they feel that you are too good, they'll throw a genetics question. If they are interviewing you.
Hmm?
And when you go for an interview and they feel they are too good, then they throw in genetics question. If they are very good with morphology, all these things about the pathology and everything.
Which kind of interview?
A job now. Just
Okay, okay.
that's it. You know, say, this guy is so good, man. So when you go for job interview, some places they'll not only ask you normal job questions, they ask you real pathology questions. And so they will even give you slides to look at. Like introduction to genomic changes. By the time you watch this video 2-3 times, there's nothing you will not know in basic breast. I think I'm too confident in these videos. God have mercy. Introduction to genomic changes in breast cancer. The Human Genome Project and High Throughput Technologies. ARI CGH. What is CGH? Comparative genomic hybridization. Next generation sequencing have enabled whole genome analysis, allow detection of copy number alterations, mutations, and gene fusions. These tools help clarify the biologic behavior of tumors, identify therapeutic targets for precision oncology. Challenge is in particular vast and complex data sets. What is CIN? Chromosomal instability is the hallmark of cancer, including breast cancer. This includes gains, losses of chromosomal segments on entire chromosomes. By the way, can you differentiate for me cytogenetics? What are the types of genetic testing, Can I classify them?
Genetic testing.
Mm. Okay,
Is it not all those ERPR?
no, those are IHCs.
Hmm?
Those are IHC testing now. Okay, differentiate molecular testing from
Is it not those Lumina A?
those are those are all those are IHC. Okay, of
No,
course,
those are molecular.
very good. So what's the difference between molecular testing and cytogenetics?
Those immunohistochemistry is just antibody reactions.
What's immunohistochemistry now? I said cytogenetics and molecular testing.
Cytogenetics, you are just analyzing the cells. Then molecular, you are, going to the
Give me,
gene in the cells.
give me examples of cytogenetic testing.
That's like fish now.
Fish, yes.
Mm.
I just guessing. Now, not you. I'm gonna fish and what's it called? Karyotyping. Now,
Okay.
if you can see what is going on, that's a cytogenetic test. Like here, this is a karyotype. Although even this is a schematic one. If you can see what's going on, that's karyotyping. Inversion, translocation, fish. You can see the fusion. This is karyotyping. These are all cytogenetics. If you cannot see what's going on and I'm plotting it for you on a graph, that's molecular testing. Real-time PCR. You can't really see the structural changes. In fish, cytogenetic testing, you look at the cell, look at the nucleus, and see in real time, see the real thing happening. The cytogenetics, the cytology of the cell. It's like cytology, but molecular cytology. You are looking at the cell. You are able to see it microscopic or whatever. But as for molecular testing, you are actually depending on emissions or graphs or something to bring out the things for you. Examples of molecular testing:
PCR.
PCR, reverse transcriptase PCR, quantitative PCR. What else? Next generation sequencing, right?
Mm.
That. So these are all. So always when you say genetic test, find out is it a cytogenetic test or is it going to be PCR? And a lot of time when we report translocation, they will report both the cytogenetic translocation, the molecular changes. For example, when you say translocation 1517, which is found in acute promyelocytic leukemia, that's the cytogenetics that you see on karyotyping. But the molecular fusion is PML RARA gene. So RA gene, that's the fusion. you will amplify the fusion. You use PCR, pick up the RNA that is expressed and amplify it. And when you amplify it, you now plot a graph or something like that to know. You now know the area. And then the difference is that in cytogenetics, you can see a lot of things happening at once. You can see many things. You can see many trisomies, many monosomies. You can see more than, like for example, now there's a kind of AML that we call it AML with complex karyotype. When you see more than 3 cytogenetic changes in a karyotype, we call it complex karyotype. You can see many things at once, but you can't do that in molecular testing. Molecular testing, you go in knowing what you are looking for. You look for a probe that shows translocation 1517, that shows PML rara fusion. You already know the disease you are looking for. Then you put in the probe to multiply it and bring it to quantitative levels to be able to identify it on your graph. So in molecular testing, you are going in, knowing the mutation, knowing the disease, and you're now using probes to search for what you're looking for. In cytogenetics, you don't know what's going on. You just go out and you run the test and then start looking at the karyotype to know exactly what is going on there. And so that's one advantage of cytogenetics. But the disadvantage of cytogenetics is that cytogenetics can only be done well in rapidly multiplying cells. Are you with me? Because you want cells that are undergoing mitosis. You remember, you are when you harvest these cells, you have to stimulate them to undergo mitosis. You have to put in mitogenes that will stimulate the cells to start multiplying. As these cells are multiplying, that's when they get to the anaphase or something like one of the phases in the cell cycle, that's when you can now have the opportunity to do karyotype. If the cells to multiply, you cannot do karyotyping, you cannot do fission. And then karyotyping takes longer time. Unlike fish that takes 24 to 48 hours, fish is actually the fastest part of cytogenetics. But the advantage of molecular testing is that you don't need a cell that is rapidly multiplying. Some of the cancers may have gone quiescent. So they will not go for cytogenetics. So what they do is that, but they will also continue to undergo gene expression. In gene expression, the DNA is not rapidly dividing. It's just going from DNA to RNA, RNA to protein. It's going to transcribing and it's translating. So they do reverse transcripted PCR. So these cancer cells these genes, mutated genes in the cancer cell are coding for something they already know. So you pick up, by the time they transcribe to the mRNA, you pick up the mRNA and use reverse transcriptase, which is an enzyme that takes RNA to make DNA, and reverse transcribe to the DNA, then amplify it. You now look at the DNA to see the changes in the DNA you are looking for. That was about molecular testing. I hope I didn't talk too long.
Yeah, you try.
But usually it's very, I'm doing impact right now. So I learned all this things when I'm doing impact. Impact has a lot of molecular. So anytime you're doing a test, you have to make sure that, am I doing a molecular test? Am I doing a cytogenetic test? I've been mixing all these things, and it's not good when you go for an interview. I don't know there's a difference between the two kinds of genomic testing. So when you do genomic testing, we have to know what kind of testing we are doing. Fish.
Let me scroll up. I want to check something. The introduction is okay. That's it. There's somewhere they talk about loss of in low grade. You have 16. Yeah, it's okay. You can go up a little. It's okay. It's okay.
Well, let's start. I was about starting reviewing the big. I'll be fast.
Mm-hmm.
So the human genome product have sequenced everything. So mutations, gene fusions can be detected. Fish can detect gene fusions. PCR can also detect gene fusions. These tools help to clarify biologic behavior of tumors, identify therapeutic targets for precision oncology. Sorry, Charlie, interpreting these things can be vast and complex. Now, the hallmark of cancer including breast cancer, include gains or losses of chromosomal segments or entire chromosome. This is
So
cytogenetic.
in luminal A, what happened? What is gain and what is lost?
Luminal A.
It's low grade.
Luminal A is just talking about we are not even talking about
I said something about 16p loss or 16q loss or something like that.
That has nothing to do with Lumina A or Lumina B.
I saw it here. You saw it. I saw for
And
low grades. Yeah, but I didn't.
maybe Lumina A may have those. We'll come there quickly now. So the more aggressive subtypes, CIN is chromosomal instability. Chromosomal instability is associated with more aggressive subtypes of tumors. Why dysfunctional tumors and also TP53 and retinoblastoma gene mutations, which are tumor suppressor genes. I would say that since Lumina A is a low-grade tumor, most likely it's not going to have a lot of cytogenetic abnormalities or chromosomal instability may be low in it. Techniques for genomic analysis. We have conventional cytogenetics, which visualizes chromosomes, karyotypes, detects large translocations, and aneuploidy. Then we have comparative genomic hybridization, which detects gains, genomic gains, losses across the genome. It identifies CNA, copy number alterations with prognostic value. We have in situ hybridization, such as fish, or what's fish? I forgot what is fish.
Fluorescent in situ. Fluorescent in situ hybridization.
That's fish. What is fish? Fluorescent in situ hybridization is fish. Chromogenic in situ hybridization. So they use a chromogen color changer. Here they use a fluorescence. It's the same test, but either they use the fluorescence now, the fluorescent, or you can just use just pure color changer, something like that. So it is fluorescent or chromogenic in situ hybridization. Remember that we use it for HER2 testing. Do you remember?
Yeah.
What is the trigger for HER2 genomic testing with fish? HER2 neo 2 plus, remember? You do reflex. You remember now?
No.
Remember we said that if you have HER2 neo, that is 2 pluses, you do reflex testing. You know that?
Yeah, that's true.
Yeah, you do reflex testing. And then look for copy number with an equal to what?
Is it 4?
4, and then SEP2 ratio or something like that. So I can't remember. But yeah, thank God we recorded it. So I have to go back to it. So HER2 amplification can be done with fish. Loss of heterozygosity detects or deletion of tumor suppressor genes and all that. Common genomic alteration detected by CGH, comparative genomic hybridization. I won't memorize all this unless they ask me in the exam. It's a recurrent gains. Do you want us to memorize it?
No.
Recurrent losses. Oh my God. Clinical applications in tool practice. Genomic tools in practice. Classify tumors, predict response to therapy, and guide targeted treatments. So we use genomics to classify tumors. A lot of tumors are not classified based on genomics, no longer morphology like that. We also predict response. Also, morphology can be used, but we classify them a lot based on genomics. Predict response to therapy and guide targeted treatment. Examples of clinically relevant fusions are these. The one we should memorize are these. Secondary carcinoma, translocation in secondary carcinoma.
1215.
Yes, and
It's
this,
actually the asthma of the fusion gene than, I don't know.
yes, which because this is the molecular test. I don't know if fish can show this also. What is the cytogenetic test? Any of these can be in the exam. That's it. I didn't know this before. I thought I can just memorize this and leave it. You have to know both the translocation and what you know that when they translocate, what happens is that they will now start expressing this. This is the gene that fuses that will now be transcribed into an mRNA and now be transcribed to protein that may cause problem for the patient. This is the gene fusion. Then adenoid cystic carcinoma. What are other ETV6 NRK positive tumors? K3. I've forgotten. So remind me, dear Lord. Cephalic carcinoma, at least I know that one. What other ones do you remember? Infantile fibrosarcoma. We've had this picture before, remember? Infantile fibrosarcoma. What else? Anything secretory. Secretory breast carcinoma. Of salivary gland.
I might not.
Acute
myeloid leukemia.
But it's rare in children. You know, the acute myeloid leukemia in children, they has a KMT2A mutation. I don't know why they are mentioning ETV6 and ROTK3.
So you have secretory and some things in children. Secretory breast, secretory carcinoma, and then things that occur in children, infantile fibrosarcoma, congenital mesoblastic lymphoma.
Acute myeloid leukemia. Okay. Then just location 6-9, which is MYB fusing with NFIB. Let me show you something that helped me recently. Sometimes when you see something, it helps you more. But we're not wasting time on it, so fear not. ETV6, this is fish. I don't want that. I want translocation. Good. Translocation 1215. ETV6 NRTK3. I'm looking for a very good translocation sample. So this is the ETV6. This is ETV6. You can see ETV6. Then this is NRTK3. So now the NRTK3 has a PTK. I'm going to show. So this fuses with this. I'm not sure how that happens now. ETV6 NRTK3. These are all molecular testing. You see, they're giving us graph. These are all molecular tests. This is molecular already. Look at the infantile fibrosarcoma, congenital mesoblastic nephroma, secondary breast carcinoma, EML. I mean, this is will keep coming up again. Translocation 1215. ETV6 NRTK3. Then MYB. So what is the translocation for adenoid cystic carcinoma? What's the translocation and what's the gene fusion?
MYB NFIB translocation 69.
Yes, translocation 69. MYB NFIB. They'll always ask all these questions. Let's see. This is the MIBG. This is the NFIB. So there will be cut off here. This is 6, chromosome 6. Q23 this is chromosome 9. They will kind of I don't know how to do it, but I'm looking for a good karyotype. Here, look at it here. This is cut here. This exon here. and this is cut here. Then this is cut in this blue, and then they join together or something. MYB, NFIB, chromosome 6, 9, 6, 9 translocation, 6, 9. MYB, fish, we picked it out. We'll see the genes fusing with each other. MYB, NFIB fusion. Our molecular tests. If you need to translate, I used to know how to read those molecular tests a little bit of few time ago. But it's okay. I don't know now. I forgot it. Okay, that's it. So these are the clinical relevant ones. They say we should know. I don't know if cystic carcinoma. HER2 amplification is seen in 20% of breast cancers and are associated with high-grade tumors, which are usually ER/PR negative. It's a predictive marker for Herceptin or HER2 targeted therapies. Molecular pathogenesis for breast cancer. Tumor progression. Breast cancer involves two accumulated DNA alterations, like the BRCA1, BRCA2, TP53, TP53, HER2 amplification. Changes can promote clonal expansion, lead to CNA, chromosomal number or copy number alteration, alter gene expression, and tumor evolution. So let's look at genomic signatures, low versus high-grade tumors. What's the DNA content of low-grade tumors?
What is what?
The DNA content of low-grade tumors is diploid or near diploid.
Okay.
I have one
Yeah,
chromosome.
that's what they talk about.
One chromosome now. One chromosome for
Loss or gain. That's the cytogenetic.
yes. That's the one. Those ones will be with high-grade tumors. That's the one that have aneuploidy. Low-grade tumors don't really have aneuploidy that much. You understand? In the exam, if they give us a karyotype, and all of them are 2, 2, 2, 2, 2, 2, 2, 2. That's a low-grade tumor. But if you say karyotype and there's some monosomies, only one chromosome 14 and another one. Now, anytime you have more than 3 chromosomal problems, they're dealing with a complex karyotype. And aneuploidy means either you have a trisomy or a monosomy. So for low-grade tumors, you have only diploidies. You don't have monosomies. You don't have trisomies. What's aneuploidy? What does it mean?
That means it's not a multiple of two.
No.
I'm not very sure. It's maybe odd. Odd number.
Exactly. Unemployed just means not two. That's what it means. Even for is unemployed, yeah, I think. So unemployed means two. Sorry, unemployed means 1 or 3. Diploid is the normal one. One from father, one from mother. So low grade tumors, you know, we don't have a karyotype picture here. But if I show you a case of, let me show you a case of AML. A very, very quick showing. You will understand what I'm talking about. Expert part. Acute myeloid leukemia. Acute myeloid leukemia. Actually, but let me see if it's going to be here. Let me see if I can get you characters. Look at this. These are the examples I wanted to show you before. Wow. This is how a low grade tumor will appear. Are you with me?
Yeah.
Why is this normal? Is this a cytogenetic test or a molecular test?
It's cytogenetics.
Cytogenetic.
It's karyotype.
Yeah, good. We can see the chromosome. We can see what's happening. We are not looking at a graph. If you look at this, two, 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 two.
The last one, 1-1.
No, because it's a male. X from mother, Y from father.
Okay.
So XY is still a pair of sex chromosomes. So all this is 46, 23.
Okay.
Okay, yeah, sorry, so is it correct? Well, let's go to this. Let me see if I can find AML with complex karyotype. There's one that I saw the other day. Let me see. Okay, my own leukemia with here. I think I see it here now. We're gonna say pediatrics. Okay, my own leukemia pediatric. Let's see. Oh, God. I don't like this, but what are we gonna do? Good. Can you see this? What can you see? A lot of what?
All single one.
A lot of monosomies. This is called monosomy.
Monosomy, yeah.
Yes, if it's three, what would that be?
Trisomy.
Trisomy like Down syndrome, trisomy 21, chromosome 21 position or something like that. So this monosomy 5, monosomy 7, monosomy 3, 4, 14. And once you have up to 3 abnormalities, either an inversion, it can be an inversion, which we don't have here, but or monosomy or trisomy. That's up to 3. You change the name to what? Complex karyotype. That's significant instability. That's complex. In fact, here they say highly complex karyotype because they even have up to this is fourth monosomy, fifth monosomy, and they say monosomy here. It's supposed to be XX or XY.
Okay.
So this is like 7 monosomy. This is highly complex karyotype. So when we're looking at high grade tumors, low grade will show you diploidy or near diploidy, highest 1 monosomy or 1 trisomy. But high grade will show significant aneuploidy or complex karyotyping. Then we'll come to HER2 amplification. HER2 is only usually positive in high grade tumors. So it's common in high grade, rare in low grade. So if you see HER2 new positive, most likely that's going to be ER/PR negative tumor or high grade tumor. P53 mutation, common in low grade or high grade. Well, which one
Hello?
has more P53 mutation, high grade or low grade?
What do you say? I
Which one?
agree, we have P53 mutation.
Yes, high grade will have P53 mutations. Very good. Which one have greater C? What is CME? Copy number alteration.
Okay.
I've not even studied exactly what a copy number is. But one of these days, I'll study it. Which one has higher copy number alteration? High grade tumors. Okay. Proliferation index. Which one has a low proliferation index?
Low grade.
High grade has high Ki-67. Which one has frequent losses? Like the monocystic, like loss of short arm, loss of long arm. Which one has more frequent losses? High grade. So 16q is actually associated with low grade tumor. Let me see what they asked here in the question. The question said, let's see 16q. In high grade tumor, 16q loss is typical. This is a very bad question. So when you find 16q loss, so are you there?
I'm there.
In what kind of tumor do you find loss of 16q? Low grade tumors or high grade tumors?
Okay. This one is say low grade.
Yeah, it's low grade.
That's what I was saying that I saw it somewhere.
But low grade doesn't mean Lumina A. Oh. Yeah, you're right. Lumina A is actually low grade. Yes. Oh, that's why I've been looking for it. Yes. So low grade tumors is where you have 16q. What are the losses you have in high grade tumors?
They have mutation, aberrant mutations. But aberrant mutations like TP53. So
Class. Don't talk. Be quiet. In the class. I'm in class. Yes. Obey parents. Obey your parents. Yes. Thank you. Parents do. So 17p, 1p, 19pq. You're obedient. Now, frequent gains. What are the frequent gains in low-grade tumors?
frequent.
Gains that you have in low-grade tumors.
Yeah, that
One,
one
one
because
Q.
something
And for those mentioned it was, let's leave it.
16Q, 1Q.
Yeah, 16, 16.
That's what I was trying to say. You see 16Q, 1Q gain. No, that was 16Q loss, 1Q gain.
Yeah, 16Q loss, 1Q gain. And this one
That's what I was trying to say the other time.
begins at 8Q, 17Q, 20Q. Gene expression studies reinforce this molecular divergence. Similar genetic changes are seen in DCIS, suggesting that molecular heterogeneity begins early in tumor development. Can you explain that statement? This statement here.
Then the first molecular similar genetics as seen in this suggesting that molecular heterogenesis begins early in tumor development. Now, all these genetic features we say are in low grade and high grade carcinoma. You can also see them in DCIS. That's what they are saying.
Yes.
And the implication is that molecular heterogeneity did not start when a tumor become a cancer. It
Yeah.
starts from even from when it is a DCIS.
Yes. Okay. Right. So correlation with tumor grade. Number and complexity of copy number alterations increase with tumor grade. HER2 amplification in position 17q12. So HER2 is amplified. Why HER2 is associated with high grade tumors is that you remember that 17q HER2 is found in position 17 and 17q is one of the tumors amplified. So you found in 17q12. The prototype of CNA associated with increased mRNA and protein expression is almost exclusive to high-grade carcinomas. That's why 17q loss is frequent. Okay, 17q gain is part of high-grade tumors. And that's why this 17q12 gain is what is actually responsible for the amplification in HER2 news. HER2 news is actually gaining an extra chromosome, 17q12. Extra short position 12 is extrally gained. And it's almost exclusive to high-grade carcinomas. Low-grade carcinomas genomic profile. The gains are 1Q, like you say, 16Q loss, 1Q gain. Other gains are 11Q, 6Q, 17Q. I don't know, but the 17Q is also found in high grade. That's what they told us. 17Q12. That's why this is so complex, man. Losses are 16Q, 1P, 8P, 8, 11Q, 10.
This was something I want we have to come back, find a way to them. I don't even want me to memorize them.
I think you have to, when you practice, you get to know them.
Mm.
Common in low-grade DCIS, LCIS, invasive lobular carcinoma. That's when you use low-grade carcinomas. Shared changes suggest common molecular regions. High-grade carcinomas overexpress MYC, HER2 new, P53 mutation loss, RB also. Extensive copy number alteration and chromosomal instability. Similar patterns are found in high-grade DCIS. So can I explain this?
Chromosomal instability, summary points. Chromosomal instability central to Okay, sorry. Overexpress extensive. Which one do you want me to explain?
This slide.
The diagram.
Yeah.
The diagram on the left.
On the yes, yeah.
No, I can't explain the diagram. Yes, I don't. I'm not so interested.
They're not interested. But if these things are real, oh, they come out to yeah, they influence
The
like
diagram. Hybridization,
I don't know.
cytogenomic, I read cytogenomic hybridization. You have patient DNA, you have reference DNA. So patient DNA and there may be control.
Let's use Mr. C and try. So we want to see how comparative genomic hybridization CGH and array CGH. There are two kinds of CGH. One the main CGH called comparative genomic hybridization and array CGH, how they detect copy number alterations, what they call CNAs. That is like examples of copy number alterations are what? What are examples of copy number alterations? Deletions or duplications. Like deletion 5q, all those kind of things. Those are copy number alterations in tumor DNA. This diagram shows how we can compare tumor DNA to normal reference DNA.
Then I'm not sure this one is IE to Jonas so that you don't spend so much time on it. I think it's
Yeah,
and in this particular guy.
I believe it's high yield though. If you are Nigeria, it's very low yield. But if you are
But what we already know the mutations that occur. We know that um you know the examples secretive cell carcinoma, ETPC, NTRK3. You know that in high grade you have more of aberrant mutations. So I think those ones.
it's okay. Let's leave it then. Why why I like this is that if you understand it from the first principle, some of these things it helps you to be able to
uh,
that's how it's done, it helps you later. Okay,
Because
look.
of the limitation of time, you can
So
understand.
which one is this?
N1 DNA fusion gene associated with adenosine carcinoma.
Okay. Okay, you see the translocation. Some part of this, the chromosome 9 went to chromosome 6, was cut off and brought here. This one was cut off and sent here. NYB, NYB, NFIB fusion. Okay. Translocation what? 6-9. Okay. So tubular carcinoma is low grade. That's what they're telling us here. With very few chromosomal alteration. When that most low grade tumors have very low cytogenetic changes.
Maybe there's no-
Vascular black carcinomas have changes in the DNA as 16q. That's like a low grade tumor. Loss of 16q. E-calorie is actually located in 16q22.1. That's why it loses E-cadherin. This is the gene, the location that codes for E-cadherin. And again 1q, 16q. You lost 16q22.1. Lobular carcinoma, low grade tumor, and gain 16p. What's the treatment for invasive lobular carcinoma? Hmm?
Treatment for
Eh?
invasive lobular carcinoma.
Yes.
Uh, Surgery.
Do you do chemotherapy for them?
Mm, not sure.
We do for invasive ductal carcinoma. We give yes, we give them, yeah, they can. Use of oncotype DX, endocrine therapy, targeted therapy. You know, we do endocrine DX to strategize. If the risk is more than 25, we give chemotherapy. If it's less than 25, we'll give what? Endocrine therapy. Remember,
Mm-hmm.
oncotype DX, we count from 1 to 100 to 35. Oncotype DX is usually ERP, is made for eliminate cancers with less than 3 positive lymph nodes. Use here 2 new. Is this positive or negative?
Negative.
This 0 plus, 1 plus, 2 plus, 3 plus. Hmm? I'll call this 1 plus. Thank you. Are you there?
Yeah.
Is this 1 plus, 0 plus, 2 plus, or 3 plus?
For anti no membrane staining. Which
Which
one are they staining now? Soma?
one? Hmm? So what will we call this? Are you there?
Mm-hmm.
So this one, is it 1 plus, 2 plus, 3 plus, or nothing?
It's loss. No membrane staining.
We're not staining, right? Good. This is fish for head too. This is estrogen receptor positivity. Ki-67 low grade tumor. This is high grade tumor. With significant pleomorphism. High grade carcinoma. What score is this head tuning? Hmm?
Mm. Membrane staining is prominent. That'll be 3.
This is 3 years. What is this? What is this? Fish for head too. Estrogen receptor. High Ki-67, high grade tumor. Mhm. Okay. Are you there?
Yeah.
Let's quickly review this quickly and then we are done. At least let's finish this question before we go. You'll be the one to take this discussion for this part. We already done,
Okay.
we already done the major work already. So
Okay. So the development landscape of low-grade versus high-grade breast tumor. Low-grade tumor, simpler genetic profile, common genetic changes, loss of 16p, gain of 1K, 1Q, and 16p, diploid DNA content, phenotype erosion positive, R2 negative, no proliferative index, like we have. Example of low-grade tumors: colossal cell change, hyperplasia, epithelial atypia, epithelial ductal hyperplasia, epithelial lobular hyperplasia, classic lobular carcinoma in situ, low-grade.
what are the classic genomic changes of low-grade breast cancers?
What do you say?
Look at this. Explain to me. But so what are the classic common findings, genomic findings in low-grade tumors?
We have loss of 16p, gain of 1Q and 16p, and diploid DNA content.
Yes, diploid DNA content, meaning that they have complete chromosomes. They don't have either excess or too little. And then loss of 16q, gain of 1q, 16p. Then what was the HER2 status of low-grade tumors?
Negative. They are
KI67.
positive.
Yes, I guess
No
67.
progression.
Very good.
No.
Let's can continue. It's low-grade DCIS. Is high-grade DCIS part of an example of a high-grade tumor or a low-grade tumor? A low-grade lesion. Is high-grade DCIS a low-grade lesion or a high-grade lesion?
High-grade GCIS.
Yeah.
You could call it low grade.
It's high-grade lesion.
The truth looks like a carcinoma.
That's that anyway. It's actually a high-grade lesion. What of pleomorphic lobular carcinoma? Pleomorphic lobular carcinoma in situ. Daisu.
Okay. All right. Do know we need to round up this one.
Okay, continue.
As an example, low grade tumor as listed, high grade tumor complex. The, the deletion form a low grade family that is genetically and phenotypically related, often developing through a shared molecular pathway. Law of 16q is a hallmark distinction. 16q loss
There's
is a
simply
hallmark distinction for
low-grade tumors.
low grade
We have to know the
tumors.
low-grade tumors. Loss of 16q, gain of 1q, and 16p. Okay, let's continue.
High grade tumor complex genetic profile, common genetic changes, amplification, HQ70q and 20q, frequency TP53 mutation, MY and R2 amplification, low frequency or cystic loss. Phenotype ER negative may be R2 positive or triple negative, high proliferation rate, and aneuploidy. Example: high-grade DCIS, high-grade invasive ductal carcinoma, pleomorphic lobular carcinoma.
Mm.
Green extrarenal grade tumors are fundamentally different, indicating a separate molecular evolutionary pathway from low-grade tumors.
Mm. Excuse me, I'm sorry. Stop. Okay, good. So, yes, stop, yes. So, very good. So, what are the classic genomic alterations in high-grade tumors?
One of what?
Classic genomic alterations in high-grade tumors.
The usual was it called aberrant mutations and translocation.
Aneuploidy, P50.
And TP53 mutations, mites and I2 amplification, low
Yeah,
frequency of system loss.
yeah. Particular is actually associated with low grade. So they'll have very low frequency of particulars. What are the phenotype? Phenotype is like IHC. Okay, phenotype, I don't know. They are unemployed is a phenotype. I don't know what they mean by phenotype. But unemployed, HER2 positive, triple negative, high Ki67. Examples are high grade D cells, pleomorphic lobular carcinoma in situ. Pleomorphic lobular carcinoma, high grade invasive ductal carcinoma, I would say. Okay, I think this is a summary. Can you go to number 3?
While low-grade tumors rarely progress to high-grade, distinct molecular features. Loss of distinct is frequent in low-grade tumor but rare in high-grade. When
Okay.
systemic loss is present in high-grade tumor, it's via different mechanism. In low-grade tumor, physical chromosomal deletion. In high-grade tumors, loss of heterogeneity or mitotic
Molecular diagnostic.
recombination.
Mitotic recombination. Okay.
So this support the condition that low-grade tumors rarely differentiate into high-grade forms and instead represent distinct lineages.
I actually used to think it's a continuum, but the
Mhm.
genomic signatures are different, showing that they are not the same kind of tumors.
Yeah.
Number 4.
Usual ductal hyperplasia, non-clonal or rarely clonal, no single genomic concentration, can still serve as non-immediate precursor to low-grade cancers. Atypical ductal hyperplasia, 15% show genetic alteration, linking them to low-grade DCIS and invasive carcinoma. Shares was the CNA pattern with low-grade cancer, 16 kilo loss and 1 kilo gain. What's CNA pattern?
Copy number alterations. Examples, all these 16Q loss, all these things we talk about 16Q loss, 1Q gain, 16P gain, then all these things are copy number alterations. These are copy numbers altered. Okay.
So, atypical lobular hyperplasia and SCIS, genomically indistinguishable, show more losses than gains, strongly linked to adjacent invasive lobular carcinoma. These findings support the idea of a low-grade lobular lineage that parallels the low-grade ductal lineage in terms of genomic behavior and progression risk. Exception and special consideration. Pleomorphic lobular carcinomas. High-grade, more aggressive variants of lobular carcinoma shows additional genetic alterations. Represents an exception to the low-grade pathway, suggesting progression of differentiation can occur. This differentiation in other tumor systems, analogous to
I don't
hematology.
get something here. Do you understand the last statement? Represent an exception to the low grade pathway. suggesting
Which one?
the differentiation can occur.
No,
Just
no, no, no.
passive
High grade, more aggressive failure of black carcinoma shows that this true genetic alteration represent an extension to the low grade pathway model, suggesting progression. So that means that normally, maybe lobular carcinoma, is it high grade or low grade?
passive lobar carcinoma is actually low grade lesion.
Yes, but pleomorphic form of it is high grade.
Meaning that it's the only one that can, normally low grade doesn't progress, but invasive lobar carcinoma can actually undergo the differentiation to progress to pleomorphic lobar carcinoma.
Okay, maybe. Yeah.
Mm-hmm.
This differentiation is another tumor type. Analogous to hematologic malignancy, chronic to acute transformation, liposarcoma, where differentiated to dedifferentiated, thyroid and salivary tumor. Thus, while progression is slow, biological, plausible, and documented in specific breast cancer subtypes and other tumors.
Do you know all this?
Summary table, DNA content, okay, deploy, low grade and high tumor comparison. Okay,
teaching PL.
wait, let's move on, let's move on. Let's have it.
Okay. Let's go our questions and random. This one will do the questions or not?
Hmm?
This one will do questions.
Yeah, let's do questions.
Okay.
Any question? We now remain, it remained two questions. We couldn't finish the.
As well. Okay. Get started. Which chromosomal alteration is most frequently associated with low-grade breast carcinomas?
15 kilos.
1P, 1Q gain, 16P gain. Two, gene amplification is most commonly seen in which type of breast cancer?
High delicacy delta carcinoma.
Which of the following best describe the DNA content in low-grade carcinomas?
Diploid.
Yes. Which molecular mechanism is responsible for 16q loss in high-grade tumors if present?
Mitosis depending on loss of ethnicity.
Yes, if 16q loss is present in high-grade tumors, it's either due to mitotic combination or loss of heterozygosity. Yes. What the level of heterozygosity? That is one parent didn't contribute. No.
PTPC NTRK3.
Hmm.
Also seen in weak ones.
Which of the following is significant? Yes.
Also
Yes.
seen in weak tumors. Which other tumors?
Congenital mesonephric blastoma or something. Infantile fibrosarcoma.
Fibrosarcoma.
And secretory carcinoma of the salivary gland. Acute myeloid leukemia. That will be,
Secretory carcinoma of the breast.
yes, and secretory carcinoma of the salivary gland. And shall
Okay.
12, 15. So this is all
Okay.
genomic changes and molecular pathways in breast cancer. Then the next set of questions, precursor lesions and low-grade family. Which of the following precursor lesion is most strongly linked genomically to classic lobular carcinoma in situ?
Critical lobular hyperplasia.
UDH differs from ADH in that
Usually show genomic alterations.
which of the following best describe HER2 and ARO status of most low-grade breast cancers?
No good. Okay. R2 negative, we are positive.
Which precursor lesion is most likely to exhibit 16q loss and 1q gain, mimicking
No
low-grade
good.
carcinoma?
So atypical data hyperplasia
Yes.
is a low grade
Low-grade lesion, yes.
disease.
Which statement about columnar cell lesions is true?
Let's say to associate with system failures.
All those low-grade lesions. Yes. There are only three high-grade: pleomorphic lobular carcinoma, high-grade invasive ductal carcinoma, and high-grade DCL. Those are really three high-grade lesions. Progressions and exceptions. Which of the following is considered an exception to the idea that low-grade tumors don't progress to high-grade tumors?
Pleomorphic lobular carcinoma.
The major distinction between low-grade and high-grade breast carcinoma pathways lies in.
What are genomic changes?
So how does that work? Low and high grade follow distinct molecular pathways defined by genomic alterations. What is the
Yeah.
significance of finding HER2 amplification on chromosome 17q12?
So then we benefit from axis targeted therapy.
Yes. Remember that this is 17q12 is a copy number. So when you see it amplified, that's an example of a copy number alteration. So when you have copy number alterations greater than or equal to 4, that means you have this 17q12 amplification, maybe some 18q loss, or those are copy number alterations greater than or equal to 4. That's why 17q12. And then has a two new HESEP ratio or something. High yield facts. Which of the following chromosomal regions is commonly amplified in high-grade tumors?
Application 17q.
17q. That means there's lots of 16q for low-grade amplification of 17q, especially here 2 new in high-grade tumors. Which of the following is the key difference between low-grade and high-grade DCIS?
High-grade versus copy number, including TPC, minimization, and axis application.
That brings us to the end. So thank you very much. We have only 2 questions left. I wonder when we'll be able to do it. Let me know when next we'll be.
So maybe what?
Let me know when next we'll be free.
Uh, ah, if I'm free this afternoon, I'll let you know, let's say between 2 and 4, or even any moment from 12 o'clock. Okay, you'll be sleeping now. So let's say
12 o'clock is my 7 a.m. We can try it now. We can try 12 o'clock. Just call me 12 o'clock, 7 to 9. Just that we are going for an appointment. So we'll be then we do. So let's try 7 o'clock, 7 to 9. Then I'll do my we'll do, yes, we are going for an appointment. I'll calculate it. Just call me. What of 11 a.m.?
11 a.m.
Yes.
Okay, it's possible. It's possible.
Just call me at 11 a.m. Let's see if we can do it 11 to 1 so that I can prepare my family. We are going for an appointment. Hopefully we can finish it and then we'll have the videos complete. See, please.
Okay.
Thank you very much.
Welcome.